you everyone for your valuable points on evaluation of hoarseness.
Good afternoon, everyone. I know it's a post lunch, very sleepy time. I hope talking on sleep apnea will not cause more sleepiness to a lot of you. I try to make it as brief as possible. The whole issue started when Mr. X, a 48-year-old gentleman, came to me with history of snoring, and he's been having this snoring from childhood. So once he became an adult, he was having a lot of problems with basic issues like excessive daytime sleepiness, not able to work properly, etc., etc. So he went to a lot of hospitals for some kind of treatment. So he was advised CPAP trials by most of them. Unfortunately, he just could not afford to do it. He could not use it. It was just incompatible. Finally, somebody asked him to come and meet me. And that is how this gentleman came to my hospital. Since the sleep study was already done, I just checked the AHI, which was about quite severe, about 91. But as we say, looking at the AHI is not something which makes you decide whether you should go in for a surgery or not. And his oxygen saturation was falling to as much as about 77%. And he was moderately obese. His BMI was about 32. So since the flexible nasopharyngeoscopy is the next step, and I was curious as to why he just could not tolerate a CPAP, I did a flexible nasopharyngeoscopy. So as I passed the scoping, I found that the nasal aperture was very, very narrow. And this was the reason why he could not tolerate. There was no deviated nasal septum, not much of a turbinate hypertrophy. But the pyrgo aperture itself was very narrow. So this sets me thinking as to what exactly I should do for this procedure. And then I thought of dome. So dome is otherwise called as distraction osteogenesis maxillary expansion. Now this is a surgical technique which we use with adult sleep apnea patients who have narrow nasal openings and a high arch palate because they have been mouth breathing from childhood. Now, normally when you have these mouth breathing children, you are able to use a maxillary expander and it opens up the palate. But in adult, the mid-palate suture lines are already fused. So, a normal maxillary expander cannot be used in this condition. So what we next do is three osteotomies which you can see. You have two osteotomies on either side which is parallel to the nasal floor, that's like the Leacoat type 1, and the third one which is done right along the midline because we want to separate the mid-palatal suture. So this is how this technique is done. And after that, when the maxilla comes into this, separates the maxilla, both maxilla into two separate halves. And then using the maxillary expander, we are able to increase the width so that new bone formation will come in, and as a result of which this narrow, high arch palatal arch will become more dome shaped. And that will widen the palate, and thus the nasal floor also widens. And it's not just that, it also improves the expansion of the paranasal sinus. Everything moves more laterally so that the whole thing becomes a better, wider area. So at the start of the surgery, what we have to do is a maxillary expander. What you see there is a maxillary expander which is attached to the molar tube by our orthodontist. Now, you can have two types. This is the one which is anchored to the tooth. There is also another one which is the bone attached maxillary expander. Actually, practically speaking, the bone attached maxillary expander is quite expensive. It's about 25,000. Whereas 6,000 rupees. So this also works equally well, and this is attached to the molar tooth before the surgery. And then along the maxillofacial, we start with the surgical. So the surgery is done with the incision which is put along just above the root of the teeth from the first molar on one side to the on the other side. That is the extension of the incision. And after that is done after infiltration, of course. And then we elevate the periosteal mucosa. And once we see the piriform aperture, using the osteotomy, we put a incision parallel to the nasal floor right up to the pterygomaxillary junction. So this is a blind technique. So using the osteotome, we have to be very careful because we have near the pterygomaxillary junction, we have the internal maxillary artery, which should not get injured. So it's very clear, when you have that osteotome, it gives a ringing tone until we reach that junction. And that is when the tone becomes dull. And that's how we realize that we have reached the pterygomaxillary junction. So that's where you stop on each side. So once you stop it on either side and that those two osteotomies are done, the next thing that we do is we go into the middle part. So there, first the septum is elevated away from the nasal floor, because in this case the patient did not have any kind of a deviation. It was just almost a straight septum. So I just had to elevate the septum up. And once the septum was elevated up, then we just elevated the mucosa from the piriform aperture, so that we had the raw bone there. And then came we put in a osteotome and went along the mid-parietal suture. We wanted to release a mid-parietal suture. So there are two ways in which it could be done. My maxillofacial wanted very badly